On behalf of RSNA, thank you for joining us today. I am Dr. Carolyn Meltzer, an RSNA board member and liaison for the COVID-19 task force. As you work to address COVID-19, I wanted to let you know that this webinar is one of the many ways RSNA is trying to reach the radiology community by providing education and resources on COVID-19. You can find these resources on the COVID-19 section of the RSNA's website, which is updated weekly and sometimes daily. A link to this page will be provided in the resources panel. Now I would like to introduce our moderators, Dr. Richard Sharpe and Dr. Brian Kuszyk. Dr. Sharpe is a breast radiologist with a background in private practice, process improvement, the business of radiology, and research. He was previously the interregional radiology chief at Kaiser Permanente, a multi-specialty private practice. And recently, he's transitioned to the Mayo Clinic, Arizona. Dr. Kuszyk is a private practice physician from Eastern North Carolina and a member of the RSNA COVID-19 task force. I now will hand things off to our wonderful moderators.
Thank you, Dr. Meltzer. With us today, we have Dr. Lora Barke, Dr. Sandip Basak, Dr. Bob Mittl, Dr. Gautam Agrawal, and Dr. Antonio Luna, as well as Mr. Dhruv Chopra. Before we formally introduce the speakers, there are a few things to let you know. You may follow the steps on the screen and in the chat panel to claim 1 CME credit for this webinar. Here is the disclosure and accreditation statement. And the RSNA disclosure statement, or disclaimer statement, sorry. Please use the question panel to submit your questions during the webinar. This webinar is being recorded and it will be posted on RSNA's YouTube page within about 1 business day after this event. Dr. Kuszyk will now introduce our panelists.
Thank you for joining us. I'd like to introduce our panelists. Lora Barke is Medical Director of Invision Jobe, largest provider of breast imaging services in the state of Colorado. 2019, she was awarded the title of Fellow of the FACR for her outstanding teaching of diagnostic radiology and significant contributions to clinical research and literature, all with the goal to save lives through early detection. Dr. Basak has been a neuroradiologist at the University Radiology Group since 2003, during which time he's held various management positions in that organization, and he's been president since July of 2019 with general management oversight of all clinical and operational activities. Bob Mittl is a neuroradiologist, Charlotte Radiology, and has served as president of the group for almost 9 years. 2.5 years ago, Charlotte Radiology combined with a financial radiology specialist, grown to be a scale radiology practice that is substantially physician-owned and led. Mr. Chopra is Chief Executive Officer of Collaborative Imaging and their respective divisions, and has 15 years experience as an executive with multiple billing companies in the radiology industry. Chopra formed Collaborative Imaging to combat revenue loss and workflow inefficiencies in radiology practices. Dr. Agrawal is co-founder and CIO of Vision Radiology, which is an academically oriented teleradiology practice. Finally, Dr. Antonio Luna is CTO and co-owner of HT Medica, one of the largest private imaging companies in Spain, with more than 20 outpatient imaging centers and running the radiology departments of 7 private hospitals in Andalusia. He also serves as the scientist director of the Spanish Society of Radiology and part of the editorial board of Radiographics and World Journal of Radiology. I'll turn it over to Dr. Sharpe to ask our panelists their first question.
Excellent, thank you. We would like to address each of the panelists with our first question. And that question is, what are the top 2 major changes that have occurred in your practice due to COVID-19? Please remember to restate your practice setting before responding. We'll start with Dr. Barke.
Hi, and thank you. I appreciate the invitation. Thank you, Rich, and the RSNA board for inviting me. I am a member of Radiology Imaging Associates, a large subspecialty private practice group based in Denver, Colorado area. And in addition to all the hospitals that we serve, we have 11 outpatient imaging centers with a large focus on breast imaging. In our outpatient practice, we did experience a major change in breast services, as you can imagine. Before the state order was enacted, our practice decided to stop all screening studies, and the majority of those studies were actually screening mammograms. This was certainly a dramatic drop in volume, but a necessary change. It led us to consolidate services and only doing diagnostic workups and biopsies that were important in ensuring that we were taking care of our clinical breast disease in the community. It was very important for us to continue in this fashion to ensure that we were actually serving our local community in this capacity. The major change on the hospital side of our practice was really a shift to home workstation to keep as many physicians as safe as possible. Fortunately, prior to the pandemic, we had invested in home workstation. Our interventional radiologists were our boots on the ground, and they covered all the in-house procedures so that hospital-based radiologists could be shifted to home. Thank you.
Excellent, thank you. And would turn it over to Dr. Basak next.
Thank you. Let me start by thanking the RSNA and the moderators on the panel for putting together this informative event and inviting me as a panelist. University Radiology is a group based in New Jersey. It's a hybrid private practice with 22 private imaging offices, 11 hospitals, an academic department with 2 radiology residency programs, and a wholly owned 24/7 teleradiology subsidiary. We interpret 1.9 million exams a year and have about 150 radiologists in all subspecialties, and our practice spans over 100 miles in New Jersey. The first major change involved patient access, and just like almost every other radiology practice in the US, we redesigned the manner in which we interface with patients. In March, we quickly implemented a paperless pre-registration workflow, which allowed for symptom screening and the creation of a virtual parking lot waiting room with patients waiting in their cars until they were ready to be imaged. And these changes had significant downstream ramifications as we needed to design an entirely new workflow. The second major change that occurred was an unabated focus on PPE. There was and has been a sustained focus on procuring all types of PPE, especially KN95s and N95s. We've developed an online process to systematically inventory our PPE across the practice and calculate a daily burn rate per office so that we can better forecast a reserve that may be needed for any future viral waves. Each manager in our offices enters their office PPE volumes into an online database that is reviewed weekly by our management team. Thank you.
Thank you. Next, Dr. Agrawal. It's on mute.
Thank you. Thank you to the RSNA, the moderators, and my co-panelists. I really appreciate the opportunity. So again, my name is Gautam Agrawal. I'm a radiologist and co-founder at Vision Radiology. We're kind of an unusual academically oriented teleradiology practice for what that means. We currently cover about 3% of the aggregate volume of the United States. I think 155 hospitals or so. All of our personnel work from home, so we didn't have much of a transition with a shelter-in-place type of environment compared to most other practices. One of the things, our practice covers about 6 time zones of hospitals, and the radiologists are distributed, I think, over 14 time zones. So one of the interesting and odd adaptive things that we had to do in March, towards the end of March, we saw quite a rapid drop in volume, inclusive of ERs, right, as they were essentially turning away people that didn't have critical or life-threatening issues or COVID. So we saw a relatively rapid drop-off in volume. So one of the things we did is we really took advantage of our time shifting and kind of global scale to kind of reduce hours, add where they needed to be added, and people just adapted to those kind of adjustments in schedule. I think that was very, very rapidly adapted as we hit a nadir sometime in mid to end of April, at which point things started ramping up dramatically, and we just started adding workforce both in hours and extent and whatnot. And I think we're now back to something like the 95+% of the pre-COVID levels. In addition, one thing that we saw during the course of this is dramatically higher recruiting, and we can talk about that in a little bit, but I think that was a substantial move forward because there was a dramatic increase in need for reading and interpretive services for us.
Excellent, thank you. Next, we'll turn it over to Dr. Luna.
Hello, everyone. Thank you for the invitation. It's my pleasure to be here. Well, my organization at HT Medica is one of the largest imaging companies in the south part of Spain. We have more than 20 outpatient imaging centers, and we also run the radiology department of 7 private hospitals settled in Andalusia. We have visits from more than 2,500 patients every day and more than 80 radiologists in our practice. The main challenge during the outbreak was to manage a very reduction in volumes, as all my co-panelists said before. We have significant different patterns in patient between outpatient centers and department located in the hospital. So we have to introduce specific adjustments in processes, circuits, and workforce in a almost weekly or daily basis. There were general measures for the whole organization, such as implementing teleworking to all the assistance departments of our organization, promoting the use of virtual conferences or accelerating the degree of digitalization in different aspects of our organization. Also, another key point was the optimization of redistribution of radiologist workflow for boosting new strategies and bring to the front project usually put on the back burner, such as research, training, or quality improvement. Also, especially painful were the measure implemented to reduce costs, such as unpaid layoff or advanced holidays of the workforce, and also to adapt the number of radiologists and workers to the changing situation. You have to take into account that we have the pandemic 2 months in advance than in the US, so we have less information that you have, and so we will have to deal with a very unstable scenario. Thank you.
Thank you so much. We'll turn it over to Mr. Chopra.
Thanks, Dr. Sharpe, and thank you to the RSNA, the moderators, and the co-panelists for this putting this presentation together. I'd also like to thank the physicians and the staff at the front line for everything that you all have done in regards to help combat COVID. Collaborative imaging was started 2 years ago. We represent about 550 radiologists spreading across 8 states. Our radiologists have imaging centers that they own, as well as hospital-based groups. We do about 9 million studies a year today. We see about 7 million patients in our operations. And, the 2 major changes that we made in our practice was, number one, we had to utilize technology to a far greater extent. The number 1 priority of ours was to make sure that we continue to deliver patient care, that we continue to make sure our referring physicians are getting what they need. And in order to do that, we had to defend our front line. And that meant getting physicians out of the hospital as far as possible and keeping physicians there as well, but making sure that turnaround times don't suffer, that if a referring physician needs to contact us, they have a way of doing so. If they want to review images with the radiologist, they have a way of doing that. So we had to incorporate a large amount of technology in our overall practice. The second thing that, the second change that occurred was this focus on cost containment. We realized very quickly with the pandemic, what's happening is the payer mix is changing. You have a lot more of self-pay patients coming through who once used to be commercial patients. Those patients would have typically paid a lot more, and the practice would have been earning a lot more money. In addition to that, with the volume dips that occurred in the practice, a practice has to adopt cost containment strategies. So we use a lot more data to identify where are the opportunities to reduce costs, where are the opportunities to be more efficient. And luckily for the group, it's worked out for the most part, and we've been able to cope with the impacts of COVID. So thank you.
Wonderful, thank you. And Dr. Mittl.
Thank you. Thank you for this opportunity to the RSNA for the chance to participate in this panel. I'm the president of Sharpe Radiology. We're a large subspecialized private practice in Charlotte, North Carolina. We have over 100 physicians and over 25 APPs. And we're part of US Radiology, which is a group with a lot of large private practices. We work together at a scale enterprise to get things done. Some of the changes that we've seen with COVID include everything mentioned by the other panelists, but a few things that we also saw was the need for closer coordination by leaders across our enterprise, and that had the gratifying outcome of a closer, better working relationship with our hospital system. It was always a strong relationship, but we've bonded even better and are aligned even more than we were before. And also within our own group, better cooperation across physician leaders and between physician leaders and administrative leaders through our COVID response task force and continual meetings that we had around those. Other panelists have mentioned the extension of remote clinical work and some of the other forms of remote work and virtual work that we've moved to in response to this crisis have included a remote interactive consults through the Microsoft Teams platform where we can share the screen with referring doctors rather than having them come into the reading room, virtual care for our interventional patients, both pre and post procedure, a remote presentation for interdisciplinary conferences and tumor boards, and now remote teaching for medical students and non-radiology residents. We don't have a radiology residency, but we do have other specialties that we teach. Rather than having them breathing over your shoulder, we now do remote teaching. And so, and the last thing is more remote administrative work, which has, actually succeeded and worked better than most of us expected.
Thank you very much. Next question that we want to ask the panelists: what were the most important adjustments you made to your practice to mitigate the impact of the pandemic? And I'd like to start with Mr. Chopra.
Thank you for the question, Dr. Kuszyk. So the first change that we made as far as the impact of COVID was, to make sure our physicians can provide care remotely. If you think about it, that's much more than teleradiology. Historically, hospitals have been against the concept of having radiologists be outside the confines of the hospital. They accept it for nighttime reads, but overall they've been much more pressing, if you will, and forcing groups to have on-site coverage. Well, with the COVID pandemic, we had to get doctors out of the hospital. So technology, coordination of that, making sure we have load balancing. Historically, because of our groups being as large as it is and as diverse as it is, we have many different PAC systems that exist. So typically you have a radiologist, you walk into a reading room, they have 8 different PAC systems, 8 different stations set up on their desk. Well, now we've taken that radiologist out of the hospital. They don't have the benefit of having those 8 stations. They're going to be reading from home. So we had to deploy technology that allowed that all to be combined into one. So whether the doctor is sitting in Raleigh, North Carolina, whether they're sitting in Pennsylvania, they have to have the ability to see what other doctors are reading at any given time and what PACs and what different systems the other groups are using. In addition to that, we focused on the touchless model. We want patients to come into the imaging center where they don't have to, talk to anybody. As far as the front desk goes, they don't have to pay bills at the front desk. They can literally walk in, walk out, after they get their procedures done. We want to have that mode of, sterility, if you will, in our imaging centers where patients come in, there's no waiting in the lobby or anything like that. And then finally, we focus on the revenue cycle side of the equation because this has taken a big hit on the revenue cycle component. So we have to identify opportunities as to where we can improve revenue flowing in quicker, where we can improve charges going out quicker, so we can keep that flow going to keep the practice operational. Thank you.
Thank you very much. Next, we'd like to hear from Dr. Barke.
Hi, yes, it's Lora Barke again. And what we did is actually a number of things. Some of have been mentioned, such as aggressive flexing of physicians and staff based on clinical needs and volumes to ensure that we were taking care of our patients and our referring physicians. We were very nimble in consolidating and closing in our outpatient center sites that were not necessary to limit the number of staff exposures and physician exposures. It also led to some immediate furloughs to mitigate some financial impact. We also created a tele back office. So we moved over 40 staff members to home within the first 3 weeks. There was also obviously an implementation of infection policies that occurred across our facilities. And fortunately, we had a lot of these in place already to respond to Ebola from many years ago. One of the other things that we found really interesting now that we think about it is that our communication changed tremendously. We probably communicate more than we ever did pre-COVID. And that's both internally and externally. So we have weekly huddle calls with the entire practice. The board meets twice a week now instead of once a week. Weekly internal COVID education updates were provided for the radiologists during the peak. There were so many journal articles and publications that were coming out that we felt it was really important to keep all of our radiologists in touch with what was happening because things were changing frequently. So this was led actually by one of our thoracic radiologists that put together PowerPoints weekly to make sure that we were all keeping up with all the important changes that were happening and discoveries with regards to COVID. As was mentioned, you know, a lot of touch points with web conferencing was performed so we could keep in touch with our interdisciplinary team and particularly with breast cancer conference and all the other tumor boards that happened. Externally, it was really important for us to ensure that we were communicating with our patients. So the patients knew which sites were open, what services were still available, if there were needs and they wanted imaging studies that could be done in an outpatient center rather than having to go to the hospital. It was also important to communicate that to our referring physicians as well so that they knew where they could send their patients safely. And in addition, our hospital partners, we communicated with them obviously throughout, but having those important lines of communication so that they knew that their outpatient partners would have availability for their patients as well. I also want to touch on one other thing an important discovery that we had when we actually began to ramp up. And it just outlined the fact that, you know, mitigation actually occurs way before any sort of pandemic. And it was an interesting discovery as the ramp up began because we discovered that we returned much quicker to volumes than we expected. So our pre-COVID volumes actually reappeared quite quickly. What we discovered is that there's actually no hack to building relationships and trust within the community. You really need those ahead of time before you even kind of come into any sort of disaster. This may be a dress rehearsal for us. We don't know what's coming in the future. We didn't actually have to deploy any special campaigns. It was really just a diligent approach to managing restructuring our scheduling post-COVID. And we found that our management teams during the peak of COVID were actually busier than ever planning our return to business. Thank you so much.
Thank you, Dr. Barke. Finally, Dr. Basak.
Yeah, so we made two impactful adjustments, just looking at it globally rather than getting into extreme detail. The first was to quickly mobilize a leadership team that was comprised of senior physician leaders and executives. And this internal task force met 7 days a week and was charged with leading the response. A key guide that we used was a daily dashboard that included office and hospital volumes, scheduled exams, staffing levels, and actually those employees that were quarantined or with positive COVID-19 status. And this nimble task force made decisive operational decisions, anything from ranging from closing modalities in offices to developing HR policies, procuring PPE, and interfacing with our hospital partners. This task force communicated effectively with frequent company-wide emails, town halls, and a weekly newsletter. And we also created a separate internal political action committee comprised of key leadership to tackle regional, state, and national political issues facing our practice. The second adjustment we made was the deployment of non-physician staff and radiologists to maximize safety and minimize economic impact to the company. So on average, during the peak of the pandemic, we reduced radiologist staffing by about 40% on average, and non-physician staffing by about 44%. And most of our 200 business office employees were told to work from home. Because we have about 115 of our radiologists out of the 150 that already had workstations prior to the crisis at home, we were in a unique position to allow our radiologists to read remotely when possible right away. And that minimized on-the-ground radiologist staffing. And we also quickly triaged our office and hospital interventional cases that minimized the deployment of our interventional radiologists.
Excellent. Now we would like some input from the audience. So everyone participating, if you could please look at the polling section in the chat box to answer the following question. At the height of the pandemic, by what percentage was your total practice volume decreased? And we have choices ranging from 0 to 100% by 20% categories. We'll give everyone just a minute to answer. Again, we're all answering using the polling section in the chat box regarding at the height of the pandemic, by what percentage was your total practice volume decreased? Excellent. So reading the polls in real time, about half of the people on this call, on this webinar, so there are about 88 participants, about half of you said that during the height of the pandemic, your total practice volume was decreased by 60 to 80%. Another 30% of people said 40 to 60%, so roughly half. That is reflective of a lot of what we're seeing around the country, and consistent with an article that Dr. Kuszyk and Dr. Mosa and myself recently put into Radiology. So we'd now like to talk with two of the panelists about what was the short-term impact of the pandemic on your practice, and we'll start with Dr. Agrawal.
Thank you. So again, this is Gautam Agrawal from Vision Radiology. We're an emergency teleradiology practice by and large. So one thing that was illustrated by one of these essentially black swan events for us was that the model that we have actually has a sufficient amount of elasticity and durability. I think we kind of got down to about 60-ish% of our previous, let's say, pre-COVID peak at its worst, and that rapidly kind of came back up. But we used physicians and time shifting and things like that to make sure that we didn't, we didn't furlough anybody, we didn't, let anyone go during that period. I mean, it was, we all kind of banded together as a group, as a team. I think that's one short-term thing that people had talked about before with their management teams kind of binding together and kind of growing together. I think everybody really stepped up in that way a lot, and we all kind of sacrificed a little bit so that no one would have to pay the ultimate price in their job, and I think that was extraordinary to watch that happen. A couple other things that and Dr. Barke, I think, mentioned something about strength of communication, and I think that was one thing that from our inception we had viewed as an important and critical thing. And so it wasn't so much a change, but it reaffirmed that these ideas of communication are critical. We call in almost every result, whether it's negative or positive, we review it with the clinician. And think about that in the context of a radiology practice, right? I mean, calling in all the negative results, that's unusual to say the least, but it's high touch, high communication. And when you're practicing teleradiology, it's very easy to get isolated. Well, this counters that. And so it continued to keep us right in the center of clinically what was happening. So I think that was one of the things that was illustrated in our practice. In addition, I guess one thing is that, again, we saw this general acceptance of teleradiology. And historically, I'm sure you guys all know, when you say, oh, I'm a teleradiologist, people kind of, lift an eyebrow or, whatever. But I think it has shifted the discussion about teleradiology, meaning most of radiology can now be thought of as teleradiology. It just means that you're reading from somewhere else, right? With the exception of procedures, obviously. So from our standpoint, one major short-term change was the general acceptance of teleradiology. And so we've seen a massive influx of people who are interested in teleradiology as a career and as a shift in how they're working. So I think those are the 3-4 things that really stuck out in my mind.
Very helpful. Thank you, Dr. Agrawal. I'd next like to turn it over to Dr. Basak.
Yeah, so first of all, there was a deep financial impact on our company, and this was the obvious direct result of a precipitous drop in imaging volumes throughout our office and hospital practice. And as soon as elective procedures, surgical procedures were shut down throughout New Jersey, and thereafter medical and surgical practices began to stop or severely restrict patient visits, our referral base dried up and our volumes collapsed. So by the second week of April, we were as low as 15% of our baseline office volumes and about 48% of our baseline hospital volumes. So clearly the impact on our revenue was profound in the tens of millions of dollars. And we did not receive any PPP funding because we exceeded the 500 employee federal limit. But fortunately, we're back to about 90% of our baseline volumes now. A second short-term impact was the significant psychological impact on our radiologists and office staff. And the extent of anxiety and fear in the early days of the crisis really can't be understated. Our internal task force's focus on managing stress and anxiety, especially for those who are truly patient-facing, such as interventional radiologists and breast imagers, was really one of our primary concerns. And this anxiety stemmed not only from fear of contracting the disease, but also individual financial uncertainty, and especially as we began to furlough some radiologists and staff members. And then finally, a third short-term impact centers around our radiology residents. University Radiology is dedicated to the education of 32 radiology residents, and the impact upon resident education was initially deep. All lectures were converted to online, and critical in-person reading sessions were converted to remote reading over the phone. But because we have had an internal teleradiology service accustomed to interacting and teaching our residents for almost 14 years, especially on the second and third shift, our resident readouts were, for the most part, unaffected.
Thank you, Dr. Basak. Now we have another question for the audience. Again, please look at the polling section under the chat box to answer the following question. Poll question number 2, how do your current total practice volumes compare to pre-pandemic volumes? A, still lower than pre-pandemic levels, B, has rebounded to pre-pandemic levels, or C, has increased above pre-pandemic levels. And we have the results coming in real time. And right now it looks like 65 or so percent still lower than pre-pandemic. 33% has rebounded above pre-pandemic levels, and 5%, rebounded to pre-pandemic levels, and 4% has increased above pre-pandemic levels. All right. We're going to ask the panelists another question related. What will be the long-term impact on private practice? Will you have different tactics going forward? Starting with Dr. Mittl.
Thanks, Brian. I remain a realistic optimist that this will not have a long-term impact on radiology volumes. It may take a year or more before things completely recover or exceed the baseline. But I do believe that there will be a continued or acceleration of the adverse payer mix that we've all seen, with more government and self-insured and less commercial payments, which will lower the collections per case per RVU and accelerate that decline we've all seen over the last number of years. Because of this and other challenges, I suspect that more and more practices will consider at least becoming part of a bigger entity, and that could take several different forms. It could be a closer affiliation with a hospital system. It could be joining a loose consortium, of which there are several out there, for example, strategic radiology, or it could be becoming part of an integrated and consolidated entity, of which there are several, and we're part of US Radiology. What a big entity can bring to a group that is seeing the challenges post-COVID is, scale and diversification, the safety that those things bring, expertise and capital. And obviously, we were talking about cost controls a little earlier. By sharing costs and MSO services across a larger footprint, that can help improve your bottom line and your physician salaries. As far as different tactics going forward, we've already established what we call our Continuous Readiness Committee. This is a group of us that were sort of the COVID task force responding in real time to the challenges earlier in the spring, doing intentional preparedness discussions, scenario planning. This sort of leadership exercise doesn't necessarily mean you're going to have an off-the-shelf solution for the next challenge, whether it's another wave, a new pandemic, or economic challenges across the country. But it does mean that you have a way of thinking and a relationship with others on your team that will just make you react better to the next challenge.
Thank you, Dr. Mittl. Very helpful. Next, we'd like to turn to Mr. Chopra.
So I think, the pandemic has definitely shown and exposed the need for practices, number one, to be more efficient, number two, to be more data-driven, and number three, the importance of diversifying their revenue streams. Practices across the country that we work with are seeing, their area might get hit, but another area that the practice is affiliated with may not be hit by the pandemic. They're seeing, because of the pandemic, they've started looking into the data a lot more as to productivity, as to inefficiencies, as to how to be a more agile practice, given the revenue hits that are going to come, given the likelihood of the increase in self-pay, the continuation of high deductible plans, which is really going to affect the reimbursement and affect the money that the group collects. So the only way a group can really survive in these kind of situations is, number one, by understanding where their inefficiencies lie and trying to eradicate those. I think you're going to find groups that are going to become a lot more technology focused. There are going to be many, many more applications out there. You're going to have referring physicians wanting applications, on their mobile phones and mobile devices that notify them of abnormal studies that they can view images on. Security is going to become a big concern as to, with all this, remote reading, with all the distribution of images all over the country. Security is going to be a big concern. PHI, how are they going to deal with that? This is going to force practices to somewhat evolve to the next level and have a business component to them, where they're definitely going to have the non-physician experts, if you will, on the business side of the equation. I do believe that you're going to see groups coming together. They don't necessarily have to sell out. They don't necessarily have to join another group or anything like that. But I do see groups are going to be looking at this and saying, what are the other options out there for, phase 2 or phase 3 of something like this that could happen that will help us, leverage ourselves and make sure things continue to flow through. I think one of the big things that's happened with the pandemic is it's also exposed some of the issues that large consolidators have. We've seen large consolidators declare bankruptcy. We've seen large consolidators lay off physicians, cut salaries in a big way. And the importance of not having debt on your books. From that perspective, I think that's going to also be something that's going to resonate with physician groups across the country. I also think it's going to be much, much more data-driven. There's going to be a lot more transparency into the data as far as, the costs, where the money is coming from, what book of business should you go after. I think boundaries are going to be crossed. There's not going to be any more state restrictions that, okay, we only have to read for this state. I think you're going to see a lot more teleradiology prevalent across the board, from that standpoint also. And as far as tactics go, I think it's just a question of visibility and transparency to our physicians. So they're going to be able to see, what exactly is going on. How does this practice run? They're going to be much more involved in that, whether that is setting up task force, whether that's setting up a committee with physicians who are looking at the data. but it's going to be a much more data-driven practice going forward, for sure. Thank you.
Thank you very much. Next, we'd like to turn to Dr. Luna.
Thank you for the question. I agree with Dhruv. I think that one of the major concerns would be to be more efficient. For this, we need better data to manage better and specific KPIs to improve analytics of our activity. In this regard, we have tried to anticipate the recovery curve using advanced analytic metrics and a machine learning algorithm to have the center prepared in advance and with enough workforce in each phase of the pandemic. Now that we have trained in the first wave of the pandemic and we are beginning to face the second wave, we will see if this works or not. Also, with regard to the general private imaging market, I think we can expect a growth in the number of outpatient centers, at least in Spain. Hospitals were central points of viral dissemination during the outbreak. So, thus, patients have been more scared to return to the radiology department located in hospital than to outpatient centers. Also, I think that there will be an increase in the caution in new investment in the market, and probably in a secondary manner, a faster consolidation of the medical imaging sector is expectable, although there will be a chance for merge and acquisition, although probably these two factors will be related to the macroeconomic effects of the second wave that now we are beginning to have in my country. Thank you.
Thank you very much. Finally, Dr. Barke.
Hi again. So I think practices for the long haul are likely going to strive to keep more PPE and cleaning supplies stocked. It was definitely something we learned early on. Ongoing distancing and cleaning and all of that, I think, is going to be very important to ensure to our patients moving forward, whether it's COVID or even just influenza, that they're in a safe environment. I also think that long-term practices will likely keep increased cash on hand and limit fixed costs. We don't really know what the future is going to hold, and everybody wants to be prepared just in case, essentially. In speaking to, we're very lucky to have a CMO that he probably didn't feel so lucky because he came on this year and kind of jumped into this. But we were very lucky to have a CMO that was, spending lots of late hours online and kind of keeping us up to speed with what was going on. But I think long term, we're going to continue to rely on all the information that comes in. But what we recognized was that the national radiology organizations and societies were actually extremely helpful in influencing the larger hospital system in whom we work with, that what data was important and what standards are important to keep moving forward. So I think, perhaps looking to those organizations and how can we be supportive in those types of venues to create guidelines so that moving forward, everybody can feel like they have the support of those organizations, which I think everybody kind of jumped in together and tried to do everything they could to create standards for people to look towards. And now we're going to have more of those moving forward already in place.
Excellent. Thank you so much. Next, we'd like to ask another question of our audience. Again, please look at the polling section under the chat box to answer the following question. How has your practice managed recruitment and employment offers made around the time of COVID-19? And there are 4 choices. Employment offer start dates have been delayed. Employment offer salary expectations have been decreased. Employment offers have been rescinded. Recruitment employer and employment offers have not been impacted. And you should be able to select all that apply. So please put a check mark if you're hearing that employment start dates have been delayed, salary expectations have been decreased, or offers have been rescinded. If you've heard of any of those in your practice, please submit them. If nothing's changed, please submit that. And in real time, you can see that there's it's a very dynamic poll. At the moment, we have about half of the people participating say that recruitment and employment offers have not been impacted. And while that is excellent and exciting, that also means that half of the offers out there have been. And so people are showing that the largest way in which offers have been impacted is by having start dates be delayed. That's at 33%. 22% have seen salary expectations that have decreased, and 20% have seen employment offers rescinded. These are significant impacts on radiologists that are either changing jobs or seeking their first job out of training as a result of COVID. And so next, we'd like to ask a related question to this. How are you handling offers made to new hires and recruiting moving forwards? And we'll start with Dr. Mittl.
Thank you. Again, we remain optimistic about recovery. In Sharpe Radiology, we've already seen restoration of approximately 95% of our weighted volumes across the practice. We did not adjust start dates. We did not change salaries. We did not rescind offers. We felt that that would be short-sighted, even if the recovery hadn't been as brisk as it was. People we're recruiting and bringing on board are the future of our practice, and we wanted to live up to our commitments to them and maintain a strong bond between them and Charlotte Radiology. As far as recruiting goes going forward, we're full speed ahead. We've got our foot on the pedal as much as we always did. Again, we expect full recovery. We're almost there in our volumes. And also, we had been, in a sense, over-hiring anyway, because burnout is a challenge across many radiology groups. And we wanted to make sure we were staffed generously so that we could offer more flexibility. We could offer options as far as lifestyle and work style to the folks coming on. This is not just a younger generation thing. This is a multi-generational, from boomers to millennials, are really looking for ways to overcome burnout. So we were trying to take the big picture, not the short-sighted picture. And we are recruiting heavily this year, as many as we planned to as of a few months ago. And again, we did not rescind, change, or drop any offers.
Excellent. Thank you. And Mr. Chopra, if you could respond as well.
Sure. Thank you for the question. I'm pleased to report that none of our groups rescinded any offers. We all went ahead and we hired the physicians that we're planning to hire. Now, I think, the dynamic that one has to keep track of is, on one hand, we have practices improving their efficiencies, right? So this pandemic brought to light the inefficiencies that exist in the workflow, the inefficiencies that exist and just, technology. So we've cleaned that up and we've seen our physicians become a lot happier. They're more motivated. We've seen, the stress levels go down because they don't have to deal with images that are not complete. They don't have to make phone calls and ask for comparisons. We've taken care of all that stuff. We're notifying physicians automatically through use of natural language processing when there's an abnormal study. So we've rolled out those key technology initiatives, which has really resulted in our groups being a lot more efficient. But we're still bringing on physicians because it's the right thing to do. I completely agree that, the future of radiology is bright. We definitely want to make sure we're bringing on more radiologists, but it's not so much to absorb the work that we had today. It's because the growth that's coming in, they'll be taking that. Because I think today where we are, after removing the inefficiencies in the process, we have seen the productivity just go up dramatically. And that's not that the physicians are having to work more or there are these, targets that they have to hit as to RVUs or anything. It's just that we've taken away the bottlenecks that was slowing them down. In addition, I think as far as recruiting goes, one change that we are looking to make, and we have made in some instances, is in regards to reimbursement. How are physicians getting paid? That notion of a fixed salary is the only thing that you get is becoming, a little archaic now, where physicians want to be able to earn more if they perform more or if they want to read extra. And a lot of those strategies are coming into play as well. We have physicians who are coming to us and saying, well, what is your expectation as to RVUs? Well, what if I do more? What if I want to read after hours when I'm not on call? Can I jump in and read? How am I going to get paid for that? And we're seeing that trend happen a lot more. And it's almost like the creation of a marketplace, if you will, where, physicians can log in and say, okay, well, I want to read some studies. I'm credentialed at this hospital. I'm licensed in the state. Can I read a study? And they jump in and they read. And if they want to do that after hours, if they have time, they can do that and they get paid for that directly. So I think there's going to be that creativity on that side. But as far as recruiting goes, we haven't made any changes. We're still moving forward with bringing on physicians, and we're hiring more physicians on the post. So thank you for the question.
Thank you very much. At this time, we'd like to move on to poll question number 4. What information sources were most valuable to you and your practice as you navigate the pandemic? And please pick all that apply. A, CDC, B, RSNA, ACR, medical societies, C, colleagues, D, news outlets, E, all of the above, or F, other. And CDC is ahead. Colleagues right below it. Very good. We'll let this poll continue to unfold, and then we're going to ask the panelists another question. What information sources were most valuable to you in your practice as you navigate the pandemic, starting with Dr. Agrawal?
Thank you. So for us, it was kind of a little bit of all of the above. For sure, I would say between all the sources, I think journal articles and our colleagues were probably the most useful. We definitely tried to look to kind of more established solid sources than some of the stuff you see in more lay media. It always got me thinking one oddball thing here. You know, as physicians, we tend to think, well, you know, we should be practicing in evidence-based medicine. It always makes me think like maybe we should be practicing in evidence-based governments. You know, like because a lot of the information that we got over the course, it was mixed and confusing and just not you know, up to snuff. And I think it caused a lot of missteps for a lot of people, practices, you know, and things. So I'd say you have to take everything with a grain of salt that was out there in the press and other things, and use your judgment.
Thank you very much. Next, Dr. Luna.
We began the outbreak in late February, so there was a general lack of information in basic aspects for our radiology department, such as the needed personal protection measure or the imaging course findings of the disease. We decided to trust only on official documents, recommendation from health authorities, scientific societies, and peer-reviewed journals, particularly from the most trustworthy ones. We also try to avoid any kind of unofficial information, such, for example, not confirmed information on social media, for example, such as the worst course of the infection in patients with ACE or ibuprofen. So we at the beginning, we mostly trust only in confirmed information.
Excellent. Thank you so much. Next, we'll turn to Dr. Basak and ask a question. How are you ramping up? And we'd like to include in this question some information, a question specifically from the audience. So the audience is curious about how are you dealing with challenges related to employee testing and exposures? And then the audience is also asking about, are you requiring patients and staff to wear masks? So, you know, I know it's a little bit of a longer question and we're nearing the end of the webinar, but if you could share a few thoughts on your ramp up, challenges with testing, exposures, and then also masking.
Sure. So I'll talk fast and try to cut my answer down a little bit here. But what we did learn was ramping down was much easier than ramping up, and that surprised me in particular. So during the worst of the crisis, we had ceased operations at 14 of our offices and reduced hours at 8. And what we did to restart was we had a 6-week phased and batched approach so that we could closely monitor volumes and safety concerns. So what we did was we took, for example, on May 18th, we opened 4 of our offices, inclusive of all of our modalities, and with a reduced work week of 3 days. And then after 2 weeks, went to 5 days. And this is all obviously subject to change. We initially suspended walk-in appointments to minimize risk, but over the last few weeks have reinstated walk-ins. We've had a surge in scheduling call volumes and increased utilization of our online scheduling application, especially for mammography. But by mid to late June, we had restored full operations of all of our sites. As far as training our previously furloughed staff, it was a real challenge, and orienting staff to our whole new workflow with electronic pre-registration, our virtual parking lot waiting rooms, screening procedures, cleaning of equipment. All of this training was time consuming and required preparation of days, if not weeks in advance of reopening an office. What we also did was modify the length of the majority of our appointment blocks to allow for equipment cleaning. So for example, we went from 4 screening mammograms per hour to an average of 3. And this has been a real challenge and limitation given the surge in mammography volumes we've seen recently to about 110 or 120% of our pre-pandemic levels. So in addition to all the other safety measures that we all talked about on this panel, what we did was we also created a simple algorithm for our staff to assess patient antigen and antibody test results, because that can get quite complicated. We also significantly limited seating capacity in our waiting rooms, put plexiglass barriers up, and continuously cleaned our reception areas, even during the day and during regular work hours. So just to answer some of the questions from the audience, regarding radiologist testing, what we've been doing is following hospital guidelines. Our major hospitals have required our radiologists to get tested. We have a sputum test in New Jersey. So our hospitals have, one of our major hospitals has required us to do the sputum test. And we all get tested at least once for now. And interestingly, it's led to a couple of false positives within our practice in the last week or two that have had to go on and get nasal tests and were ultimately negative. In terms of employee testing, we have a list of urgent care centers that are pre-approved by our nursing staff that we can send our employees to if they don't go to their PCP. We've had a half the country, or more than half the country, is quarantined from coming into New Jersey. So that's led to challenges in and of itself. So finally, in terms of masking, this is interesting. We initially didn't mask in March, and then the guidelines changed and changed back. And ultimately, we obviously mask everybody, including patients. And if patients don't wear a mask, we generally don't see them unless there's a good reason that they're not wearing a mask. And all of our staff have to wear surgical masks. And we do provide N95s to our outpatient imaging staff for those who are doing pre-approved aerosolized procedures.
Excellent. Well, thank you so much, Dr. Basak, for that response. And then panel, thank you everyone for your time and sharing all of your expertise. Thank you to the audience for participating today and for the questions you asked. I'd like to now turn it back to Dr. Meltzer for our wrap-up.
I would like to thank today's faculty for sharing their expertise. Thank you also for attending today's webinar. Please look in the resources panel for details on how to earn CME for this webinar. Also, I encourage you to continue the conversation on RSNA's New Communities site, where your radiology colleagues and RSNA leadership will comment and answer questions. Please see the chat and resources panel for the link to the site. Again, thank you.